Yeah, good evening, friends. What a pleasant moment for me to welcome you all back onto this academic session of Yashoda Group of Hospitals in association with IFCCM Hyderabad chapter. And we try to bring some of those live topics which are of interest to all our intensive care and clinicians in and around. And this has been an endeavor which Yashoda as a hospital and critical care department as a scientific team has been continuing for the last 2 years or so. We have an interesting topic. I think since when the Supreme Court judgment has released in the late part of April or May, I've been waiting and interacting with Dr. Mani, who is the, I think the force behind all this. We will talk to it later. So I was talking about this area where all of us as an intensive care specialist, clinicians who are working in and around the ICU, whether with organ donation or without organ donation, are struggling to answer this question. Can I withdraw a life support if my patient is not listed for organ donation or is in line with an organ donation? This question has been asked many of the times to me also from our colleagues in and around. And we have been, to be honest, are always in asking this question repeatedly. Today we will have maybe just before this discussion, I was having some chat with Dr. Mani, who is throwing some new different perspective of all this discussion. So before we bring that interactive discussion with Dr. R. K. Mani, we'll request Dr. Durgesh, who is our senior consultant in the neurointensive care unit, who will take us through the overview of withdrawal of life support in a futile end of life situation. Where are we? What is the legal stand? And after this, it is followed by Dr. R. K. Mani, who is the chair of clinical services in Yashoda Hospitals in Ghaziabad. Dr. R. K. Mani and we as a hospital share the same name, but of different groups in different cities, and but probably serving the same purpose of sharing the academics and knowledge across the students, and we are happy to do that. And it is our honor and a pleasure to have somebody of his stature on board who can guide us, throw us light, and probably I can't think of anybody in this country who can be the authority in this area. We welcome you, Dr. R. K. Mani sir, on board. Thank you for accepting our invitation. Sir, your camera is off. Thank you. Sir, you are muted. Sir, you are muted.
Thank you very much for the kind introduction. So I'm eager to listen to Durgesh.
Durgesh, over to you.
Thank you, Venkat sir. Thank you, Dr. Mani sir. It is honor and privilege to either present and discuss with the recent topic, recent development, what we are discussing in the medical fraternity, that is withdrawing of life support in the futile end of life situation, where we stand legally. So initially, I will be discussing through the few ethical and issues. Then finally, we'll be going to legal stand. So if we see our last progress, couple of decades, like especially last 2 decades back, our ICUs has evolved tremendously. So we provide we provide organ support in the form of mechanical ventilation, in the form of renal replacement therapies, in the form of hemodynamic supports. So what is happening is we are like supporting organ, sometimes assisting the organ. The support may turn for like in the weeks or maybe days, or in some rare situation, it may turn out to be months. So the what is happening is at the point where the organ support, even if giving the organ support, may not be lead life or recovery of the patient. At that point of time, we should be considering this situation, that is end of life care support. So and we also consider that there is not a fair chance of good quality of life after recovering the patient. So we should be considering the end of life care support. So this is a famous laureate. In her book, she wrote that if the push towards the life sustaining technology were balanced With the option for comfort care, more people would have chance to transition to death with dignity and grace. So the Article 21 also, as our Indian IPC also states that the person who has a right to live also has a right to die with dignity and the grace. So our duty as a medical professional, a caregiver, is not only to mitigate the suffering, and it is to cure sometimes, to relieve pain often, and most and always it is to be comfort. So end of life care, it should be a patient centric, personalized perception of good death, which encompasses all the comprehensive care of an individual who is approaching his or her end of life. It is applicable to any person or any place having any form of illness, and it should relieve all his symptoms, which may be physical, psychological, social, spiritual, and existential symptoms. So if we consider the quality of death, what we are talking about, a good quality of death or dying with a dignity is seriously compromised if one dies in the intensive care unit or in the hospital environment. So our aim should be to provide universal access to the standard palliative care at the end of life, and every individual should have a right to good, peaceful, comfortable, dignified death. Further they mention that in presence of near loved ones or in presence of the environment which the patient prefers. Now coming back to what is the problem statement, especially in Indian scenario. So the thought process of having a good quality death or dignified death, the concept is has not been received a much of consideration. The humanistic values, palpably they are lacking in our Indian healthcare system. So there are no proper policies of the limitation of inappropriate support or life-sustaining support, where we think the sustaining life support will be maybe futile. So health-related communications, which should happen more commonly in the physician and the patients or patient relative, it considerably less as compared to the Western study. If we consider the data, almost in Western studies, almost 90% of the population will have a natural death. So to further, the Indian Council of Medical Research, they have come with the specific terminologies in the end of life care. So what they provided the definition of what is meant by terminal illness. A terminal illness is an illness from which the recovery cannot be expected with the available treatment, and death is considered to be unavoidable in the foreseeable future. Or a terminal illness is an illness which is incurable or an irreversible condition caused by any injury, disease, or illness that would cause death in a reasonable period of time in accordance with the accepted medical standard, and where the application of life-sustaining treatment would serve only to prolonging the process of dying. The other position statement or definition that has been shared in ICMR document is what is meant by life-sustaining treatment. Life-sustaining treatment is any medical treatment that artificially supports or replaces the body functions which is essential for life, like performing a cardiopulmonary resuscitation, endotracheal intubation and mechanical ventilation, vasopressor therapies, parenteral or enteral nutrition, chemotherapy support, having a dialysis support, any form of blood products, antibiotics, intravenous fluids, so on and so forth. So coming next to the withholding life-sustaining treatment. So on the background of terminal illness, a decision is made not to initiate or escalate the life-sustaining treatment. The patient's chances of survival after initiation and escalation of life-sustaining treatment is poor. So the burden of outweighing the possibility of benefit if we continue the life-sustaining treatment is outweighed, and there is no possibility of that patient is getting back to the life with the healthy and reasonable quality of recovery, that the informed patient or the patient is incompetent or surrogate behalf, the patient choose not to initiate or escalate the further life-sustaining treatment. The next is withdrawing of life-sustaining treatment. Here the decision is made to remove the life-sustaining intervention which is presently provided, where the patient's chances of survival with continued life-sustaining treatment is poor, and the burden outweighs the possible benefit, and fully informed patient, or if the patient is incompetent, the surrogate on behalf of the patient chooses to cease life-sustaining treatment. So coming back to euthanasia, so we had discussed a lot regarding the euthanasia. There is again active euthanasia and a passive euthanasia. We'll discuss further this terminology. What is meant by active euthanasia? It is that intentional act of killing a dying patient with the terminal illness by the direct intervention of a doctor for the purpose of good of the patient. So, however, allowing the natural death and withholding and withdrawing life-sustaining treatment to limit the harm and suffering a dying patient is not considered to be having active euthanasia. So, the term of passive euthanasia, even if it obsoletes, it should be avoided, as the euthanasia cannot be passive, and withdrawing a potentially inappropriate treatment in the patient dying with a terminal illness that only prolongs the dying process. That means that, so active euthanasia, where the treating doctor directly intervenes, which hastens the killing of a dying patient, that is called as active euthanasia. In our law, active euthanasia is an offense. It is a punishable offense. On contrary, passive euthanasia, with the terminology, is not very self-explanatory. So withdrawing a life-sustaining treatment or withholding the life-sustaining treatment can be termed as a passive euthanasia if the family or the treating physician consider that the life support treatment is only prolonging the dying process. Now coming back to some ethical concept in our medical practice, like autonomy. Autonomy is nothing but a right of an individual to make a free and informed decision. So it includes the patient should be having full information and should be able to participate in the medical decision making if he is able to do so, if he will to conscious or competent individual. So if he has to also refuse any form of the intervention. So the end of life treatment choice has to be, if he considers, respected. So even if the advanced treatment and their prognosis, like if it is considered to be guarded. So the right of autonomy has limitations and has again ethical dilemmas. So the next principle is beneficence. What is meant by beneficence? It is obligatory on the part of physician to act in the best interest of the patient. So the physician should have judge the end of life care situation and provide an appropriate treatment prognosis. Patient can make an autonomous choice of the treatment preferences, or the patient family can make these choices for them and work towards the act of beneficence for the patients. The physician also has to provide the information about the treatment, especially in case of futile treatment, so to avoid any undue harm to the patients. The target healthcare services is not only should target lengthening of the life of the patient, but also improve their quality of the life. So non-malfeasance, it is the simple thing. It is should not cause, first of all, do not cause harm. So the harm also includes harm to the patients, not only physical harm, also patients' interest. We have to consider their beliefs, their values, their wishes. Coming back to the fourth principle, distributive justice. Now in the medical care, in the context that all the patients should be treated without any prejudice, healthcare resources should be distributed equitably, and there is need of evaluating and assessing constantly medical advances in the treatment, and avoid any undue use of already having limited resources, considering the aspect access of quality care to the people who need the most, and rationalizing the treatment when it is futile. So what are the barriers to end of life care in our scenario? So most of us, we are unaware of what are the ethical issues. We as a culture, many of believe that heroic, that fighting till end. So we are more believing that we want to fight till end. Many of attendants, when we counsel the prognosis of the patients, many times they commit whatever that happens, whatever we do, we want patient to be alive. That culture of fighting till end is very common in our, not only in common public as well as in medical profession. So there is very improper, a lack of orientation regarding palliative care. It is not only in common people, but also in the medical profession, and legal and administrative prejudices. So whenever we think of end of life care, the other hindrance will be what are the medical and administrative prejudices. So if you see, European Economic Union ranked our country as the least or the last in the 40 countries. So we don't have a proper basic end of life care environment. Availability is very scarce, and we are struggling with the basic care, the cost for and quality of the end of life care definitely will going to be not very good standard. And in the community level also, we don't have a concept as well as sources for palliative care, except in Kerala, there are some community-driven hospice care is available. So the ICMR guidelines will state when to initiate the end of life care discussion. So if we are dealing with a patient having advanced age with a poor functional status due to one or more chronic debilitating organ dysfunction, like end-stage pulmonary disease, COPD with advanced cor-pulmonale, terminal cardiac failure cases, okay, hepatic diseases, chronic kidney diseases on continuous renal replacement therapy or dialysis, who have received standard medical or surgical treatment options, or sometimes the patients decline to have received any form of treatment, that there we can consider initiation of discussion of end of life. Sometimes the catastrophic illness where the organ dysfunctions is there unresponsive to routine therapy for a reasonable period of time. Coma patients, okay, in absence of brain death due to any catastrophic illness. So such as severe traumatic brain injury, patient is having severe catastrophic intracranial hemorrhage, extensive stroke, extensive subarachnoid hemorrhage. So, or in chronic severe neurological condition where the advanced cognitive and functional with the advanced cognitive or functional impairment with a little or no prospect of improvement, advanced dementia, quadriplegic or chronic vegetative state. And further, where the patient is having progressive metastatic cancer, where the treatment has failed and or patient is refused to take a further treatment. Post cardiorespiratory arrest situation where there is a still poor neurological recovery even after 3 days. So where are any clinical situation where the treating physician will say that there is a poor chance of survival, or patient or family preference limit to life support or refuse to accept any life support. Further, the IFCCM also proposed some ethical position statement that will consider the physician has a moral and legal obligation to disclose to the capable patient or family with the honesty and clarity the poor prognostic status of the patient, with the justification when further aggressive support appears to be non-beneficial. The physician is obliged to initiate an open discussion around the immense of death and intolerable disability, the benefits and burden of the treatment option, and the appropriateness of allowing natural death. The second, when we fully inform the who are capable patients or the families, in case of patient is not capable, is desired to consider overall treatment goal or comfort care only, the options of the physician should explicitly communicate the standard modalities of limiting life prolonging interventions, like do not resuscitate orders, or like withdrawal of life support or withholding the life support. If the patient family do not desire the continuation of life supporting intervention, the following above mentioned options are made available. Now the physician also must elicit and respect the choices of patients which are expressed directly or through their family member or through surrogate during the counseling sessions. And work should be done towards the shared decision making. He does ensure, physician should ensure that respect to the patient's autonomy in making an informed choice while fulfilling his obligation and providing beneficial care. So pending decisions or the event of conflict of the interest in the case of family, the physician must continue all the existing life supporting intervention. The physician, however, is not morally or legally obliged to institute a new therapies against his better clinical judgment in keeping with the accepted standard of care. The next guideline in the ICCM statement is the case there should be proper documentation which reflects through faithful recording, and the gist of the proceeding or further counseling should be mentioned, and there should be total transparency and accuracy in the recording of the medical recording or whatever video recording also. The overall responsibility for end of life care decision rests on the treating physician or intensivist, who must be ensure that general agreement of all members of all other fraternity who are caregivers to the team. If the capable patient or a family consistently desire that the life support should be withdrawn or he or she should be discharged home to die, in the situation in which the physician consider aggressive treatment non-beneficial, the treating team is ethically bound to consider withdrawal of life support modality in question. Although the clear legal guidelines are at presently lacking, there are certain guidelines which we will discuss. So withdrawal or withholding decision should be implemented after completing a life support limitation form duly signed by patient family and treating team. The physician is obliged to provide a compassionate and effective palliative care to the patient and to attend emotional needs of the family. Coming back to the legal aspect, so we are discussing regarding end of life care. So we cannot miss to discuss the case of Aruna Shanbag. So everybody, I think, will be aware of what happened to Aruna Shanbag. Since 1973, after a sexual assault, she was in the continuous coma state. She received a cervical spine injury as well. So she's been taken care for almost more than 40 years at the KM hospital at the respective staff, though she was in the vegetative state. Finally, on 18th May of 2015, after 41 years of long struggle, the story ended. What is the take-home message of this story? So on March 7th, 2011, sir, there was a landmark judgment given by the Supreme Court legalizing the passive euthanasia in the India. What happened was the social activist named Pinky Virani, she filed case in the Supreme Court for passive euthanasia or for vegetative, for the withdrawing of the life support because of the continuous vegetative state for more than 3 decades. So though the Supreme Court has legalized the passive euthanasia, but here the Supreme Court or the decision to discontinue the life support must be taken either by the parents, spouse, or any close relative, or in absence of them, the next friend. So next friend were the nursing staff, which is being passionately taking care of Aruna Shanbag since last 41 years. And the social activists which filed the PIL, the Pinky Virane, she may not be the next friend. So Supreme Court declined the decision. And even if the nursing staff, which are considered to be next friend by the Supreme Court, if they change their mind, then they again, if they want to have a passive euthanasia, then they have to again require a court approval. Strangely, on 25th of February in 2014, there again opinion given by Supreme Court saying that there are the inconsistencies in the previous decision, and there should be clear unification of the law. And again, the constitution of bench of this court has to be, again, we have to constitute a bench for the further the benefit of humanity as a whole. So what is the historical judgment? What in this case, the historical judgment of legalization of passive euthanasia in India, which would end the distress and affliction of the patient undergoing unbearable and prolonged suffering. With the advent of modern technology, we have failed to recognize that it is not the technology that governs and sustains human, but rather that vice versa. Every single citizen is entitled to and reserves the right to die with a dignity. Coming back to the recent judgment given by the Supreme Court, how we should proceed for the end of life decision. If we have advanced directives or the applicant for the patient who has lost the decision-making capacities, or the patient is terminally ill. So if we want to think, or any medical profession want to think, forego the life-sustaining treatment, then there should be a primary medical board formed at the particular hospital. The primary medical board should be consisting of a physician and to subject expertise with having more, at least 5 years of experience, and they should opine on whether the life-sustaining therapy should be withdrawn or withheld. Here, the previous judgment was the primary medical board should be consisting of the physician having the expertise either from neurology are from cardiology or from oncology, which have a standing knowledge of critical care and they are in the field of more than 20 years. So after again writ petition by the IFCCM, the Supreme Court has changed the primary constitution, how you constitute the primary medical board. So instead of having this vast experience of more than 20 years, now the judgment says the primary team should be having the primary treating physician and two subject experts with at least more than 5 years of experience. So the treating team to inform the patient's next kin or next friend or the guardian or those mentioned in the advance directive through the discussion, and they ensure that they understand the information provided and concur with the decision of the treating team for the foregoing life support treatment. So within 48 hours, the secondary medical board, which should be consisting of registered medical practitioner from the permanent panel of such a practitioner should be empaneled by the district chief medical officer and two more subject experts with having at least 5 years of experience and which are not the part of primary medical board. So the secondary medical board will give an opine. So secondary medical board, it concurs with the decision of the primary medical board. The decision should be, whatever the decision should be conveyed within 48 hours. So if both are primary medical board and secondary medical board, both are agreeing on the same or withdrawing the life support therapies, then hospital should record it and should intimate the judicial magistrate, and treating team shall implement the decision to withdraw or withhold the life supportive therapy. Suppose if the secondary medical board is not concurring, is not agreeing, what are the findings, what are the noted by primary medical team? In this case, if the aggrieved family or any treating team or the hospital may approach to High Court level. So again, coming back to there is ICMR consensus guideline, which has given guidelines on do not attempt a resuscitation. Here, the do not attempt resuscitation. So if the treating physician feels that there is a CPR is having a realistic chance of success, yes, then CPR should be continued, and periodically we should be evaluating the clinical condition of the patient. Suppose if the treating physician doesn't not sure or feels that there are no realistic chances, so before patient is going in that stage, we should be having discussion with the patient if it is in complete conscious. So whether regarding DNAR status or family members to be discussed, or any surrogate has to be discussed with them. So if any ambiguity is there, we should continue CPR. If the patient and the family members, they give a decision, if they accept all the futility of the care, then if they agree for the do not attempt resuscitation, then we can label it as, and we can put it down in our notes. But the final decision lies with the treating physician in the best interest of the patient. So whatever the reasons, the decision should be documented properly. And if the patient and surrogate also declines the discussion, that also need to be documented, and the decision should be reviewed periodically. So coming back to what we can take home message with this our discussion. So advanced directives, withholding the treatment or withdrawing the life support treatment has now a legal stand, but the process is tedious. We have to have a primary medical board, we have to have a secondary medical board. The secondary medical board should come within 48 hours, and if both are in the concurring decision, then hospital has to inform the district magistrate. If there is a discrepancy between, then either the patient or patient family members or the hospital or treating physician may go through the High Court. So we should be having better awareness among our doctor regarding end of life care. If we have that awareness, then we can percolate in the common public through the frequent education and various formats. And always we should be following the principle of ethics. And end of life care should be involved in the curriculum since beginning, when we'll at the graduate level, at the even postgraduate level. At every hospital, there should be end of life care committee should be there. And in the community level, there should be adequate community participation should be there in the form of end of life care and palliative care also. And we have to always remember those who have a right to live, they should have also right to have a good death. Thank you.
Yeah, thank you, Durgesh, in bringing that topic, the overview of how do we actually withhold life support and what happened over the last couple of decades or so. So we invited Dr. R K Mani sir, who has been a part of this journey of the last maybe 2 decades or so, from the beginning to till this time, and he has been consistently stood by the time to actually keep on fighting for the right of dying. I always see helping the natural death process, which he always says, allow the natural death to happen in the time when it is done. Sir, let us discuss some of the basics things which has been there in many of our minds in the intensive care teams or in the clinicians who practice in the intensive care medicine.
Sure.
The brain death, which has been started from 1994 with Organ Donation Acts, and later on has been repeatedly revised in its act, has always been linked with the organ donation. And you have been always the ambassador to talk about that key. It's a very, very small number which actually agrees for this organ donation. But you legally declare them dead if your apnea test, second apnea test is positive and true. But if the patient is, or the family of the patient is not agreeing for any form of organ donation, what happens to the next? So it is very, very natural intent or tendency of the clinician that if the family is not keen for organ donation, they just take a back step saying, hold back, I'm not clear. So this has been a very natural tendency which has been seen over the couple of decades or so. So I just wanted you to elaborate on this area first, then we will go to the concept of passive euthanasia or withdrawing or withholding of support.
You see, if there's a natural tendency to hold back, we must examine this natural tendency. We must question ourselves. Science is about questioning and using logic and applying it to mitigate suffering, not to enhance or increase or bed to suffering, right? So that is our mission and goal as healthcare practitioners. Now, the premise of a deceased organ donation is that the person should be dead, isn't it? Dead donor rule is very clear. So you recognize brain death differently from circulatory death, but both are death only. And brain death, the equivalent to death, has been described since 1969. And even our FOA recognizes that death means either you are dead by the brainstem or you are dead in a circulatory way. So the death definition is very clear. So that is the premise with which you approach the family for organ donation. So the person is dead and the family has declined organ donation, that person remains dead.
True.
That person doesn't become anything else.
True.
So it defies logic to say it is linked. Brain death definition is only linked to organ donation. That's not correct. It's defined in TOA. It doesn't mean it is exclusively defined only for the purpose of organ donation. That doesn't make sense. Because death is the prerequisite for organ donation. It is not, doesn't come afterwards. After somebody family agrees to organ donation, you don't diagnose death. You diagnose death prior. So it is unethical and not acceptable by any of the conventional standards of medicine. Recently, there was a brain death project involving so many countries, scores of countries across the world, and they had a consensus definition and consensus processes. So they're very clear that once brain death has taken place and organ donation is declined, then somatic support is not to be done, except under 3 circumstances. One is that there is pregnancy and there is a consensus to continue with pregnancy for the sake of the child. Number two, number one is the organ donation. It's a prospective donor. Number two is a pregnant woman whose pregnancy can be ongoing for that in view. And number three is if the family needs more time to understand what brain death is. That's not for indefinite period. They said you specify a time, say 48 hours, and after that you're at liberty to discontinue, because we have to see if there is a circulatory death, would you continue on the ventilator once the heart has stopped?
No.
So it defies logic that if you are dead by the neurological criteria. No, they call it not brain death, by death by neurological criteria, death by circulatory criteria. This is the new way of expressing. Why? Because there's a unified definition of death. Ultimately, it's a permanent, irreversible loss of consciousness. That's what death is. So it can either occur when the heart stops, then the brain stops. Or brain can stop directly if there is a direct brain injury of all kinds. So this is very clear and should be clear to healthcare practitioners. We should not go by unresolved fears. Okay, we have had unresolved fears and a cultural blockade of the mind. Now, how can you ever then convey the concept of brain death to the families if we ourselves have not accepted it, have not understood the concept? In fact, conversion or consent to organ donation also depends on how well you explain what brain death is. Okay, it's linked to that. So brain death being equivalent to death has been recognized in Indian law as well. In Aruna Schonbach case, they differentiated between vegetative state and brain death. In page 52 of the judgment, it says very clearly, brain death is death. Okay? So if anybody has any problem with the definition outside of TOA, that is given by the judges. And of course, we are also proceeding towards a unified definition of death. Our applications are with the government now, and there is progress. And I suppose by the end of the year, we could have a unified definition of death to further convince everybody. But however, I think, pending all these formalities, you follow what is scientific and logical and what is ethically correct. No law is going to stop you. In fact, to the contrary, if you continue like this, you are liable for for suit, and it's already happened. The one case where a young lad was continued on the ventilator beyond brain death, and the hospital was sued for keeping a patient on a ventilator beyond death, and they were found guilty and charged 5 lakh rupees. So you don't have the opposite case law. If somebody removed in the case of brain death, there is no such case law.
So just to make it more clear and pinpoint, sir, suppose you get a case in your intensive care unit where you feel the brainstem reflexes are absent, the patient is brain dead. What will be your flow? 1, 2, 3, 4, 5.
Flow will be to do clinical diagnostics has to go on. That is, you don't need anybody to agree to organ donation to be able to diagnose.
Done.
Do the clinical testing processes to diagnose brain death, you do so.
Yes.
And at the end of the first testing, it's very clear to you. Then you, after 6 hours, you do that again. But in the meanwhile, you start talking to the family, preparing them. So preparing them for the eventuality of brain death. Firstly, you talk to them about brain death, not about organ donation, only about brain death. And then once the family has come to terms with it, then you invite a transplant coordinator to offer the possibility of organ donation as a altruistic, course. So that is the flow. And then you do the second testing. And if they agree, you follow the support of the organ donor and to its culmination. If they don't, then you declare death and remove the supports. So this is the correct thing to do. And this is what I do. and I've never got into any trouble. Families, there's a closure. Otherwise, you're ambiguous. You say, no, there may be 0.5% chance, 0.1% chance. These are all not scientific. There's no chance. Once your brain testing is clearly indicates that the patient is brain dead, they don't come back. It is a, what do you call it? It's a myth that is somebody may come up.
Okay.
Okay, and that we have people of science. We don't want to go there.
We don't believe in myths and miracles, so we will stick to the scientific. So I just wanted some questions you to answer. The number one, you said you should have a clinical testing for which you don't need anybody's consent. It's a regular brainstem functioning testing. One. Second, we speak about apnea testing 1 and 2, where a set of guidelines has been put forward by the state governments and maybe the brain dead organ or brain dead declaration forms. Do we need any consent to do this test from the family, 1 or 2, any of them?
See, actually, consent is not needed. Although in some jurisdictions in the world, consent is needed because there can be some harm. Okay, perceived harm due to apnea testing. You may have hemodynamic instability or something like that. And many jurisdictions of the world don't ask for 2 testing, only 1. You do all tests for brainstem reflexes. Then you do all tests of brainstem reflexes second time, and the last test is apnea test. You see, that makes sense. You don't do a procedure which is potentially risky in the sense that suddenly patient may collapse, right? You don't do it twice. You need to do it only once, and the final time when you do all the brainstem reflex, and then you do apnea testing, it has to be in the presence of the brain death committee members, and one of whom does and other 3 observe. So this is the full thing.
But it's some reason we have 2 tests and both are apnea tests and both has to be done.
No, they are brainstem reflexes and apnea tests, not just apnea tests.
But in India, we do 2 apnea tests. Apnea test 1.
No, I agree with you. We do. This needs reform. See, we reformed many times. 1994, 2011, 2014. So this is, see, whatever is found to be redundant in the light of new knowledge, we should be able to correct. And that only we can initiate. We can say, look, most of the world doesn't want to do 2. It doesn't make sense. And on the one hand, we say, we may have to abort the brain apnea testing because many people may collapse or even have a cardiac arrest while doing the apnea testing.
So you mean to say that we probably need 2 brainstem reflexes clinical examination?
2 sessions of testing for brainstem reflexes, and culmination in the end, 1 apnea test.
But right now we continue to follow the existing.
Continue to follow. But continue to ask and reform. See, it's a continual process. No? Don't you see in the world what is happening? Every few years you revisit the issue, you want change. Why are we just slavishly following whatever was told to us before?
So there is another question which I try to instigate you. Family denies. In spite of all the efforts and counseling, family says, no, don't do apnea test. We have all the
see, family refuse any procedure, you can't do it. Now, one thing is when family refuses, now you see, to test for death, you don't need consent. In principle, you don't need. So you test for death and you declare death as a technical situation. Now, family is in denial, is common. But we must improve our way of communication, because I think that leaves a lot of room for improvement as of now.
True.
What we do is we generally say family is denying, family is refusing, family is difficult. We don't for a moment stop. Have I used the right words? Have I talked to them enough? Have I been compassionate enough? We never ask those questions. because those are the physician variables. As scientists, we know there are two variables. The family variable is a physician variable. There is a cultural and policy variables, right? The culture of the hospital. So these are all the variables. Are we giving enough time? Are we giving sufficient importance to convincing the family? We may be speaking something matter-of-factly. Have we stopped to think what the other person has understood or what the other person is going through? Or if we support that person emotionally, the understanding may improve. So these variables we start to consider when we look at communication also as a scientific process and an intervention. It's not an incidental thing. It is a crucial intervention in these situations.
So you asked one point, enough time to the patient family to take it and understand. What is the enough time? That's again a subjectivity.
No, enough time is that you're not in a hurry. You're not answering your phone. Okay. You're not distracted by other things. Okay. For some time, you leave your phone aside. Focus on the subject. Focus on the patient. Patient-centered. Be patient-centric rather than be self-defensive. There is a quality and a quantity. Now, in quantitative terms, this has been calculated. When you do all this, you need about 10 or 11 minutes. Okay, even this has been looked at. When you're not distracted, you need about 10 or 11 minutes. Some people may need more, some people may need less. But what I'm saying in quantitative terms, it is not beyond our reach. Okay. If you have a problem with placing a central line, it may take you half an hour, or it may take you 5 minutes. But there is a specific time, and that is a sufficient time we talk about. So what I'm saying is, we need to tell ourselves that it's an intervention, like a difficult airway intervention. You give yourself enough time, don't you? You don't say I have to do it in 2 minutes. You take a breath, you take stock, you plan, you give yourself time. Then you ignore all phone calls from the OPD, right?
True.
Same thing here. It's an intervention of equal, perhaps even more difficult situation. The more difficult intervention.
So clear two things. One, brain death is death. It can be declared as death, irrespective of whether the family is agreed for organ donation or not. Apnea test to assess a patient's integrity of the brainstem may not need a consent.
Two tests, no.
Two tests may not be.
Two tests may not be required. One of them, is dispensed with in many jurisdictions.
So
if you look at the brain death project, you will find it. They don't recommend two tests.
Yeah, keep on questioning. But right now, we continue to do two. Keep on questioning.
You continue to do two. Continue to ask for reform.
Reform.
And, if we make a cultural shift in our own brain, it will happen one day.
So I will like to know from you 1, 2, 3, 4 steps which you counsel the family, because you said communication is the key. How do you approach when you were seeing many of the times this is one of the biggest tasks when it comes to the only son, 18 years, gone through a traumatic, very bad road traffic accident, suddenly found on the roads and has been tubed. Really, in spite of hours of counseling, the family will be very emotional. We're just trying or wanted to learn from you the steps which you, how you progress and proceed in this.
See, the 4 or 5 principles of communication, not only applicable to brain death, it is also applicable to breaking bad news or conveying terminal illness or poor prognosis. Firstly, you must sit the family down. Okay? Not bedside, not corridor. Okay? Have a room where you can sit them down. You have verbal and non-verbal way of conveying your concern, right? Also called empathy. In the sense that you convey information fully, not through euphemism, through fact, but convey them with sensitivity, and then wait and acknowledge and recognize the emotional recording, right? The emotional support is part of the conversation. Listening is part of empathy. So if they have emotional turmoil, it's good to have them express and you to listen. That is called a therapeutic communication, right? So the communication between doctor, patient, and family is not just a statement of facts. It is got a therapeutic value, which we must recognize, acknowledge, and practice. You must acknowledge also it is difficult for both sides. It's difficult for us as well. It's not easy. But then approach it like you would approach a difficult procedure. You can't run away. Buck stops with you. Huh? You go ahead and do it. And as you do more and more of these, you get better and better, like any expertise. So communication expertise has to be developed. Many times there are communication workshops, and then there are structured ways of learning it. We have the time and the opportunity, we must do it. So one must not duck questions. One must not be in a hurry. One must not say things, just in self-defense, which may seem insensitive. All right. So the words that you use, the manner you have, body language you use, these are very important. And lastly, you must document. Okay,
So-
documentation conveys that there is transparency in the process, and it is subject to review and critique, right? So that is also important. And then when we document, insisting on signature is not always necessary. Most people, 90% of people sign. But if 10% don't sign, it's okay. You have conveyed.
Dr. Mani sir, now we are talking about this, but you may not have come across these situations, but on and off, there will be exceptional situations which we do come across.
Yeah.
There were situations where if a family pays for this end of life situation where the patient has not been showing any signs of brainstem reflexes, and they are paying, there will be a different situation. But sometimes when it is paid by some insurance, some other company, they wanted to continue for a longer time. It also plays a role in situations in spite of repeated counseling. These are all futile exercises. Have you come across? We have situation in real time. I'm not sure whether we have done adequately on the counseling part, but in spite of all the seniors involved, with all the empathy, spending hours together, because somebody else was paying the bill on the continuation, we had a kind of ethical dilemma. One side, we know the brainstem reflexes are absent. We have done a clinical testing on that, and we are reporting to the insurance company that this is what the brainstem reflexes is absent. The other side, the family says, no, we wanted to take more time, whether there is always a belief that my son will wake up of so-and-so date. So
these are exceptional circumstances, and that I've also faced. So we have to take from case to case, but out of 10, 8 of them will agree with you, if not today, tomorrow, right? So why don't focus on the 8 and do justice by them?
What do you do for
for the other 2? You keep at it. What I do is, I don't emphasize the money. I emphasize the suffering of the body. I emphasized on the spiritual suffering of the body that appeals to people, and you also emphasize on the unethicality on the part of the physician and the family to keep a dead body going like that. So you see, you have to give yourself the opportunity to talk about these things. These issues are to be touched, although they are sensitive. There are many times you ask the family, if they say, no, I want to carry on, you ask a direct question. Why do you want to do so? Okay, simple question, open-ended question. Can you share with me why you want to do?
So they say we have a hope.
You have a hope. Now, so then you can address that hope. You can say when somebody's heart stops, you don't carry any hope. We declare death. Now, this is because the heart is being artificially carrying on, but the brain is dead. You know, this is a medical reality. I must share with you that the person is dead. So sometimes the clarity is required from our part. It has to be opened up. If they have not understood 4 times, or to 5th time they may understand. Sometimes it happened with me that they seem not to understand. Next day itself, somebody turns up from the family, sir, we, मुझे लगता है अभी छोड़ दो, निकाल देते. Because something has turned in their brain. They have seen, some conscience has churned. So there are more important things in life than money. Particularly when you're facing death and such extreme tragedy, the importance of money gives way sooner than later.
Okay. So coming to the next part, this is about when you don't have a brainstem reflexes, but we have more complex situation when you have a brainstem reflexes, but it seems like the patient has gone into an irreversible or terminally ill, where the chances of any reversibility or recovery looks unlikely. There were many definitions or terminologies which Dr. Durgesh has elaborated or not, from withdrawal, DNR, DNI, all this, do not escalate and all. So this has been a common challenge, and you have gone through a road of these challenges over the last decade or so. Can you elaborate them, sir, from those days? What are the changes or reforms you have been made in this? Then we'll go to the questions. There are many questions which audience ask.
So you see, our first guidelines position statement from IFCCM was made in 2005. Okay, it's a long time, nearly 20 years back. And a lot of us have been practicing withdrawal and withholding since then. It's not about only neurological irreversibility. It's about many, many things. Durgesh showed, that has come from that guidelines. There are 9 or 10 triggers, okay, for EOL discussion. So you see, when we start to talk to families, we start to talk right from the time of admission. Within for 24 hours or 48 hours, you should talk to the family. Okay, call them. All the doctors involved should be talking to them. So you build a relationship, you build a trust. So then as the disease evolves and the trajectory is clear to you after some time, this is going nowhere and this is going to end, irretrievably, then you are in a position to open up the conversation about a situation like this, where medical interventions are not going to help. They may add to the burdens, both to the patient and to the family, not just financial burdens, emotional burdens, and to the patient, very miserable death. The quality of death is also very important, and dignity in death is extremely important. So that is why, since physicians have always had worries about law and all that, they worried more about law than ethics, unfortunately, and about caring for the patient. We should reverse this culture. We should care for the patient, really. That's our job. Law is secondary. Anyway, you have the legal sanction now after a long struggle. So you had the Aruna Schonborg, where they said you had to go to High Court. Then you had the Common Cause judgment in 2018, where they said you got to have a 3-tier system. You got to involve the district collector, you have to involve the magistrate of the first class. So that was impossible to do. But still we were continuing to do our withdrawal withholding on the basis that you have a collective consensus between the physicians and between physician and family, and you sign on it. So you have a transparent, good process of communication going on. We were doing that and nobody caught us for anything. Now you have a simplified procedure since January 23, wherein you have only 2 steps rather than 3 steps, and you don't have to involve any magistrate or any bureaucrat. All you have to do is when you have made a decision, you just inform the magistrate. It is just information. It is not taking any permission, right? It's not another layer at all. That's all right. We do notify so many things. We have a MDR TB, we notify, don't we? Huh? It doesn't stop you or slow you down in any way in diagnosis or treatment. Same way here. Now, in the second tier, where you need 3 physicians, one of whom have to be appointed by CMO, you can have a permanent panel. There's no problem. Don't we have a permanent panel for brain death
Ethics committee,
committee?
brain dead
Similarly, you can have a number of physicians from your hospital recognized for the purpose from the CMO, which we have done in our hospital. So you can do that, and then you see 48 hours doesn't mean you have to take 48 hours. It's within 48 hours. It can be 1 minute to 48 hours. Okay. So if you have permanent standing up, anyway, you have the first primary board naturally happening. In an ICU, you have a number of physicians, at least 3 with 5 years experience involved in the case. So that is already there. And then if you have a board of a CMO empaneled people, you need only one of them available anytime. So this is very doable, and we should make bold and do it. Now, I tell you, there are many very simple decision making for which you don't have to go through an elaborate process. Okay. I mean, simple refusal by the patient or the family of a procedure. Well, you can't do it anyway. You don't have to go through 2 boards to do. A withdrawal decision yes, you may need to go through this process, and so it is the complexity of the decision also. A DNAR doesn't require any boards and other things. DNAR is again by the ICMR, task force. Their guidelines are you have to discuss with the family when there is a possibility of cardiac arrest, what to do, discuss with the family, or sometimes you have the opportunity to discuss with the patient also. So if there is physiologically futile, we need not do anything. And nobody can force you to apply a medical procedure. CPR is a medical procedure.
Sir, in this context, I just wanted to clarify, sir. There were many misconceptions that DNR is illegal in this country. DNR cannot be written in the case sheets. DNR cannot be documented. So
they are ill-informed. Totally ill-informed.
Sir, that's what.
Is there any law code you can quote me that DNAR is illegal?
So now with this ICMR document, we can be well assured that this can be.
You also got the law clearly saying refusal of treatment is a right. Withdrawal, withholding now. DNAR is only a withholding. And you have a statutory body of ICMR even before the judgment. They have got a policy and they've got a guideline.
True.
So, how much assurance does one want?
Yeah. So this
for
is
a practice which has been there in the world since 1974. So if you've got fixated ideas, you have to examine, why do I carry these ideas? Yeah. Why am I saying DNAR is like illegal or euthanasia when there is no such definition?
True.
That's the definition given in your ICMR definitions. Why don't you Google search and see what is DNAR equal to active euthanasia? So why do we persist with certain misinformation?
True. So going to the question, sir, so there are some questions from the delegates. In withdrawal, it is very easy to set up a medical board once board agrees on withdrawal. How to go about the next process? You already explained, but just for the answering this question, they said it's easy to have.
Withdraw means you withdraw. So you see, there is a process. Obviously, the idea of all these decision withdrawal, withholding is to mitigate the suffering of the patient brought about by these excessive treatment modalities.
Sure.
So if you have to withdraw a ventilator, for instance, okay, some people do terminal weaning, some people just dial down, okay, some people extubate. Now, whatever you do, the distress has to be anticipated and controlled with anticipatory analgesia and sedation. You don't paralyze the patient, please. No NMBA. Because then you do not know what is going on. You just paralyze the muscles. So the distress, visible distress, should be anticipated and controlled. And then, of course, you can titrate the analgosedation as you do the procedure. The senior most person of the unit should be there. Okay? And there should be simultaneous assuring and then support to the family. So this is the way it is done. If there is, after withdrawal, patient doesn't die but continues to survive, then all the palliative care has to continue. Okay. continue with the symptom control, reduce the isolation of the patient, right? Allow more visitation, or you can move to an area where where family has access. So all those things, humanizing of ICU care
So
should be done.
do you shift from control to support to a
No, you can do directly also.
Okay.
Okay. You can do directly also.
And you extubate them, or you continue on to be on an
I extubate them.
Okay.
In Tata Cancer, they don't extubate, they continue. But then that is your practice, what you're used to. Extubation is a, you know, I like extubation because it's a completion of the process. Otherwise, you continue longer.
Any supplementation of oxygen or anything in this process?
You can give oxygen, or you know, you don't even need to continue with monitors and beeps anymore. Usually, after extubation from a full support, people pass away in 1.5 hours. You know, on average.
Most of the times.
So there is a completion. If you do halfway, then the 1.5 hours will stretch to another 10 hours. So that doesn't do anybody any good, and the patient suffers longer. So I personally, I extubate, and I have not had any problems. But I have personally done it. I have not relegated it to resident. I do it myself because it's a very sensitive process.
Yeah. Other question is, unfortunately, in many circumstances, the patient's family in a paid hospitals take the patient against the medical advice, feeling there is an extra cost for a day if they stay in the ICU for this decision making and the withdrawal of support. This has been his experience. So decision of withdrawal needs time. Is that according to the guideline? That's what is the question.
Not necessarily. See, LAMA is a failure of communication. LAMA is a failure of a doctor-family relationship, a collapse of doctor-family relationship. Because, as I said, communication begins from the first day of admission to the hospital. You build a relationship of trust, and you open up a conversation about imminent death. You know, as soon as you become aware of it, then you don't get it, because you avoid unnecessary expense. So expense comes down. You avoid those big penums and echinocandins and what have you, IVIGs and all those extracorporeal purifying agents. All that people use indiscriminately when we are not winning, and that adds to the false hopes and the anger that is building up. And then they in the anger, the relationship collapses. They say, we are taking him home. This is going nowhere. You're not giving us any assurances. At the same time, you're saying, I cannot withdraw because the law doesn't allow. That's not true. If you ask yourself, the law does allow. Your conscience should not allow this to continue, but your conscience allows it. I don't know why. So the thing is, we have now known through surveys that the culture, the ethical climate and culture in the ICU impacts on the individual decision making. If we are used to always escalating, having only one-way ticket, right? Anything happening to the patient, worse for any reason, you just ramp up. You add another antibiotic or make it more expensive, or tell the family there's no hope, yet you keep going, right? So there is discordance of what you've told the family and what you're doing. If there is no hope, they are always asking, there's no hope, can't we remove the ventilator? No. Oh, that is illegal. So that is being a little tricky, What we are doing is, we are avoiding ethical dilemmas. We are avoiding difficult conversations and difficult judgments. So that is not the best of us do, right? If we want excellence, then you've got to be a well-rounded physician who can tackle these difficult dilemmas and take it head on and do it according to best medical standards. So best practice standards will not allow lamas. Let the patient family fend for themselves. without any palliative care, have a miserable death. They don't even have the benefit of soft words from you. You're just throwing them to the wolves. That's what you're doing. And Lama doesn't protect you from the law. We know that. From a case in Gurgaon, you know that.
Yes, yes.
The
So the
child was
question-
sent Lama, and
Yeah.
they are
on the way to
roiled
the
in a long court battle. So it doesn't protect you because nobody is going to countenance. You're saying that I'm protected because I've sent Lama. Okay, because the family will say we were not told what to expect. They only said no, I can't remove. We had no option. This is what those people said, and they were all over TV and media saying the same thing. So we are not doing any great good to the public trust.
Sir, in the continuation of the first part, after the medical board agrees, that's what is the 3 people in your ICU, one with the primary clinician and 2 with the 5 years of experience. What will be the next step? There was a repeated question asking, what will be our next step? Whom do we inform, the magistrate at what level? That's what is the question again.
When do we form?
After the
No, you have taken a decision. The primary board, secondary board, both are agreed that this treatment has been
secondary board,
withdrawn.
they're asking about
You take a withdrawal decision.
Mani,
All
sir.
you do is to send a mail to the magistrate
Mani-
and you implement
Mani,
the
sir,
withdrawal.
Mani, sir, they're asking about secondary board. This is the primary board is done. They're asking
Secondary board, you constitute the secondary board. You have had a empaneled doctor in your midst, and you got 2 others, and then they also approve. Then you go ahead and implement.
that has to happen within 48 hours. Within
48 hours, yes.
And
If it
after
doesn't
that-
happen, you carry on, you continue as per the first, because that's what the Supreme Court has said. All this has to be done expeditiously. You can't take all the time in the world.
And the second part is after this 2, you have to inform the magistrate. You have
That's
to-
all. After you decided, for example, you diagnose MDR-TB. There will be somebody in your office or in the administration who takes care of these things. Okay? He will just send a mail. This is the name, this is the number, registration number. This is the decision taken. That's it.
There are some questions related to, do we need visual recordings of apnea
No,
test
no.
required?
Don't need visual record. Nobody has
There were
insisted on
questions
it.
related to, there were situations where carbon dioxide rise was not 20 in many of the apnea test situation. And we tried multiple times. What do you do in those situations?
This is a problem. Then you do ancillary testing. Okay, if this doesn't work, then you do ancillary testing.
Maybe a 4-vessel angio or a CT angio to confirm there is no blood flow, adding to this other steps. So if the family asked to extubate a patient on, let's say, 70 to 80% FiO2 with high PEEP on vasopressor suboptimal GCS,
You see, I usually then stop the vasopressin because then you don't need to extubate. When you stop because that's also withdrawal. Okay. Withdrawal doesn't mean only withdrawal of ventilator.
This question is different, sir. Suppose there is a discordance between what family thinks and what clinicians thinks. ARDS patient, sometimes in Indian context, we do come across families after a couple of days of support, they start believing the patient is already dead on a ventilator. These are not.
You have to talk to them. That's why I said the most important intervention is communication. You ask them why they believe the patient is dead. No, he's not moving. He's not moving because there is paralytic agent given. So you address their concern, answer them honestly. They will understand and they will become friendly with you.
So suppose they insist on extubating these patients, what do we do?
They can't insist on extubating a patient if the medical board does not believe the patient has nothing going. This is the whole safeguards in this business of having a consensus between physician team and family team. Okay, now you see why it is a shared decision-making process. Because if the physician team thinks this is a reversible process, we have to tell them that it's a reversible process. If it's reversible, then medically we cannot recommend extubation.
So I think we have gone through a lot of exercise, sir. Any final take-home messages from you? I think this a wonderful 40 minutes of interaction where many questions were answered. I think you have put across very crystally that as a clinician, in the best interest of the family and patient, if you work towards it with ethics and medical practice on mind, legality will take a back seat and it automatically flows. Now that on this process, that also is adding to you all your efforts on the way. So brain dead now can be declared as a dead. That's the first point, irrespective of whether the family is ready to donate or not to donate.
Yeah.
You can give some space, but at the end of the day, you're withdrawing and you can stand with that. One, you said. Terminally ill, now we are getting softened and softened with the clinical decision making, which is getting easier and easier nowadays. But it is again done in the best interest of the patient. And we do come across exceptions in all the situations where you may have a complex families, complex, every patient varies, every disease varies. Sometimes these all will be a part of it. But as you said, let us target the 80-90% who go aligned. Then we will deal this 10-20% what to do in later part. So I think that's the message you carried. And I think we salute you from bottom of our heart for the efforts you made to give the dignity to the dying patient and allowing the natural death to happen, probably stopping this prolonged suffering of all this terminally ill patient struggling on the beds. And as you said, it's not about finances alone, but the lot of other things which come across, the emotional burden, the many other things which go through the whole family, and the patient also takes a lot of burnout. And sometimes even the intensive care resources has been misutilized in this way in many circumstances. With currently we struggling with nursing numbers, with many other things, the resources has been ill-utilized in many situations. So thank you so much for enlightening us, sir, with this. And I thank Durgesh also in bringing this topic, and I thank all the participants who has been there in enlightening us. Thank you.
See, one parting shot I must give you,
sir.
That you see, if we practice ethically and from the heart, then our burnout incidents become very low. Because we also suffer. We are caregivers, and if we are not able to express our good intention and our good judgment properly, then we have a risk of burnout. That's also been very well captured in many studies. So there's everything to hope for and work for in creating an ethical climate within the ICU and acting in an informed manner with full knowledge of what death and dying needs are, and in an legally informed manner. Thank you all for this opportunity to meet.
Thank you. And I conclude the session. Thank you all.
Thank you, sir.